Sundeep Dev. I'm a physician and president of Retina Consultants of Minnesota, Minneapolis, St. Paul, Minnesota. So the idea of our study was that we observed in clinic that patients were not achieving real-world outcomes from clinical trials, especially with later generation drugs. And it was observed that the premise was that do patients who are requiring step therapy or requiring older agents before they can get to the newer agents, whether that would affect their long-term outcome and their durability for management for macular degeneration, retinal vein occlusions, and diabetes. So with that, we looked at initiators versus switchers, looking at the two latest agents, Faricimab and Aflibercept 8 milligrams or Eylea HD. Presuming that if we could start patients on those two drugs at the beginning, meaning initiators, versus people who are requiring older drugs like bevacizumab, ranibizumab, Aflibercept 2 milligrams, and then have to move to those, whether their outcomes would be different in the long run. We looked at over 12,000 eyes, and what we found was a statistically significant difference with a p-value of less than 0.01, that patients who could initiate on Faricimab and Eylea HD were able to go longer than people who were switchers and requiring older agents first. Yeah, so we kind of defined late switchers as those who required 5 or more injections versus those who could switch less. And we found that also, again, with a p-value of less than 0.01, that patients who were early switchers were able to go longer with more durability than patients who were late switchers. That was our premise. That's what we had observed in our clinical experience. And so it was nice to be able to validate those clinical observations. So I should also add that not only did we find the durability, we found that anatomic improvements followed the durability, that patients were able to get much more improvement in CST with early switchers versus late switchers, and initiators versus people who are non-initiators. In terms of answering your question about Medicare versus Medicare Advantage, we found that the trend was that Medicare patients were able to have longer durability and better anatomic results. Most likely, we would premise, is because Medicare patients don't have the same barriers as Medicare Advantage patients with step therapy. It unfortunately shapes everything, that we may have a nice conversation with the patients and talk about the clinical trials, but it becomes almost irrelevant because the insurance decides what drug they can have, and most of the time they require off-label therapy with bevacizumab before they will allow any other therapies, and sometimes there's double-step therapy requiring a second older agent before we can get to the latest generation drugs. Well, Congress needs to eliminate step therapy requirements for their patients. I would remove it completely, ideally, but as a thing, I would not require us to have 3 monthly treatments before, because it just delays treatment. And as we found, actually it usually requires 4 treatments because they have to have completed 3, and on the 4th one we don't have a prior authorization, so they're actually getting 4. And that's how we chose the number of 5 to look at early switchers versus late switchers and showed that there is an advantage to switching early. I think AI will help us with, in the future, with more accurate record keeping for patients' clinical records, but also will help us greatly with imaging interpretation and help us greatly with research as well, as we can identify patterns, and these types of observations that we make clinically that we can go study can be more seamlessly done through AI.